And welcome to the Scrutiny Committee on the 8th of February. Obviously, I just want to mention, before we start, obviously all of us know we're very sad that Dean is not with us now. And I know we've all stood and we've all thought about him, but obviously he was integral to this committee. And he was very, very helpful to me on a personal level. So just want to recognise the fact that he's not here, and we hope he's having a good time in the next world. So anyway, thank you. Obviously, you know me, I'm Jill Slocum, the chair of the committee. The agenda pack is in paper available via ModGov or directly from the council's website from the link which was sent out to members. In line with the recommended meeting procedures, I'm requesting that all members and officers turn off their microphones and videos, but please remember to turn on your microphones and videos when you speak. This helps with background noise, call quality, and anything disrupting the meeting. When I invite somebody to speak, could you clearly state who you are for the benefit of anybody who's listening to the meeting so they can identify who is speaking? Can I remind members not to use the chat function, solely for committee business? Otherwise it's distracting and there may be other questions and conversations to be had. Can I also welcome any members of the public and media who join us today? And finally, as agendas are now viewed electronically, could I request that members and officers refer to page numbers from the individual agenda packs to assist all present in finding the appropriate information. So item 1 on the agenda is apologies for absence, please.
We've had apologies from Councillor Sue Osborne, who sent Councillor Steve Ashton as a substitute, Councillor Andrew Govia and Councillor Tony Robbins.
Thank you. Do we have any other? Thank you. Item two is minutes of the previous meeting on the 7th of December, which was chaired by my deputy chairman. And could I ask you if that was a true record, please?
Agreed.
Thank you. Item 3 is to invite any members for declarations of interest. Personal interest, members of district, town and parish councils are available for inspection on the website. So is there any other further ones, please? We have none. Thank you. Item 4 is public question time. And I believe we do have a late question, which I've allowed for this question to be at this committee because I am a nice chairman. And so could we have our questioner, please, which is Mr. Ray Tosterin. Sorry, Mr. Tosterin, I've not pronounced that correctly. I apologise.
Thank you, Chair. Ray Tosterin from Quicksilver Community Group in Yeovil. I have one quick question. NHS Somerset ICB voted...
Could you speak up, please? Could you speak up?
I'm so sorry.
Can't quite hear.
Sure. Ray Tosterin from the Quicksilver Community Group. NHS Somerset ICB have voted unanimously to close the Yeovil HASU despite widespread and continuing opposition from the public, patient groups and NHS staff. At their decision-making meeting on the 25th of January, ICB members also agreed for £1.8 million of capital funding from Somerset to be spent creating a new HASU at Dorset County Hospital in Dorchester. Surely the ICB should be investing to keep the Yeovil HASU, not close it. This committee expressed serious concerns at the ICB proposals when you met in December. The ICB appear to have ignored those concerns. Will this committee now approach the Secretary of State using new powers that took effect last week to officially call in the NHS Somerset stroke reconfiguration plans? Thank you.
Thank you very much for your question. Just to let you know that this committee has spoke about this for some time over the last 18 months. And we've really debated long and hard because we obviously feel very strongly as well that this is a very, very serious issue. And whilst we respect the ICB, we believe that also there are further measures that we may be able to to deal with. So I don't want any further discussion, members, if you're happy, because I think we have discussed this. What I would ask you is, in light of this, this and other people have asked us about the approach to the Secretary of State, are you willing for me as chairman and our vice chairman to write to the Secretary of State? Could I have a show of hands, please? All those who are willing and agree to us writing to the Secretary of State.
Chair, I wish to clarify something on that.
Mike.
Microphone, please.
Chair, I wish to clarify something on that. At the last meeting, it's not a discussion, it's a clarification. We agreed to send a letter, which we did, and I had a copy of it. What then happened, because it seemed to bear no fruit whatsoever? Could you just fill me in what happened after that point?
We did have a reply. We did have a reply which quantified in great detail of the reasoning that the ICB felt that the measures that were being taken. That doesn't distract from what we feel. And I think I don't really want to spend time on debating this very important issue. I think it is a clear indication that if members are happy. So could I just take this vote again, please? Because I just want to move on and get this vote taken. All those in favour of taking this to Secretary of State?
Against.
6.
Yeah, and against.
Against, please. 1 against. Well, with that, Councillor Bruce.
Thank you. I also don't wish to enter into any debate about this. I would like to request some clarity on Somerset Council's position in terms of how Somerset Council voted at the ICB board meeting in January on this. I know that the minutes haven't been published yet of the ICB. My understanding is that our CEO, Duncan Sharkey, would be the person who would have been present and voting. I would like to know, based on the fact that the Scrutiny Committee raised concerns, the Leader of Council sent a letter raising concerns, one of the executive members also raised concerns and was seriously against this proposal, and yet it seems like it's been published that there was a unanimous vote in favour of that preferred option. So I would really like some clarity on what Somerset Council's position was at the vote and some justification. If the vote was in favour from Somerset Council, why was that decision made? What was the justification for it? And I'd like that to be made public, please.
Yes, indeed. I think we've already set that in place today. We want to find out some details. I think that the justification the ICB board has given is a very thorough one. But nevertheless, we are a standalone. We had a standalone committee, and regardless of whatever the vote was taken, we have the right to approach the Secretary of State. We can't make him. We can approach him to ask him his thoughts on this and whether we can go forward. And I believe that we'll be able to show them that we've tried as hard as we can to get good reasoning behind this. And I think that's as far as we can go on this committee, because we certainly have really worked hard on it over, many, 18 months and plus. So if you're all happy, and I'd like to thank our speaker very much. Thank you very much for coming today, because this is a very important issue, and we all feel some dilemma about this, but hopefully we'll move forward and get some answers. As soon as we get an answer from obviously our committee, we will come back to members with what was said.
I use this chair.
Sorry.
Oh, we can share it. We can share it, Jen.
Thank you, Chair, and thank you for the leadership that you and the Deputy have taken with this. Is it possible to relatively quickly, between us as a committee, have a brief comms? Because I know that residents in my area are very, very concerned. I can put something together for my residents. I will quickly, but it'd be really good if we had a unified comms on what we were doing, what our position was, and how we are representing our communities here and making sure their voices are heard. I think it's really important we do that, and it doesn't get lost that we are trying to speak up for our residents. So is it possible for a statement from the committee? I mean, I will do my own for my residents, but I'd love to have one that was more unified as a committee.
Yeah. We're happy to issue a statement. What we will do as well is when we approach the Secretary of State, the statement we give and the reasoning behind what we're asking for will be given to members, okay? So you will be fully briefed. The minutes have been very, very good. If you go back and read the minutes over the many minutes on this subject, they have been very, very clear. We have asked many questions, and there's areas there that quantifies exactly what we're asking for. The last minutes were exceptional. The questions that were asked at the last committee were very, very good. So I think if you have that, you can go by that for the interim, but we will make a statement, absolutely. And this is the last question on this subject, please.
It's not a question, it's independently of this committee, I'm submitting a call in as request anyway, which are the summary of the points raised. I'm quite happy to circulate that because it's quite a concise summary of the reasons why we're asking for a call in. And that's from the PPGs.
Well, that'll be really very, very helpful. Thank you so much. And if you can make sure certainly that obviously the chair and vice chair, us as vice chair and chair, we get that, please, Mr. Ashton, Councillor Ashton. Thank you. Thank you. Okay, right, moving on now. We have the work programme, which is pages 23 to 24. Do we have any questions, please? Councillor Bruce.
Thank you, Chair. I think I mentioned this at the last meeting as well. Workforce. Can't see it on there still. I think it was at some point on the items to be added to the agenda, but it disappeared again. So is it on there? Am I missing it?
No, I don't think it is on there, so we'll put that on.
I will go back through the minutes and see, but I think it's been a long time that we've been asking.
Go to stand up. Go back in. Apologies. Just.
Training in my glasses doing the same. There we are.
Right, thank you so much.
Sorry
Right,
about
so
that.
we'll get that on there. Thank you very much for pointing that out. But one of the things that I wondered whether we could put on, I think this might not be the right time. Maybe it is. You'll let me know, no doubt. But the ambulance service update, I think, in light of what's come out about the Yeovil service, it might be the appropriate time to bring that in again, to ask about the timings of ambulance throughout Somerset. So I think that would be a good one. The other thing I would like to ask is, and this is probably old hat really, but I still think it's very relevant. We all know that COVID is increased in our areas quite a bit. And I think it would be really nice from public health to get a COVID update to find out exactly what the position is, age groups it's affecting, how are the vaccinations going? Is the take up good? Many people I know are very anxious about that. And I think a good clean update on the COVID, would you be happy with that? Councillor Bruce.
Can we include in that one of the key lines of inquiry in terms of the booster programme or what the strategy is for that going forward? I've had a few people say, oh, is there a spring booster? And
Yes.
we're not really sure what the long-term plan is for boosters. Thank you.
Yeah, that's what I meant when I said the whole programme, but thank you for actually clarifying that bit. I think it would be really good for us to have a clear picture, a clear direction, because what we haven't got at the moment, we haven't got that. Does anybody else on the back of this sheet, if you have it on, or if you move on your online, you will see there are other areas that has come up before now. That do you want anything else added at this time? Is there anything else? I mean, if we have on the next meeting is Councillor Wood. Oh, sorry, Councillor Wood.
Can you turn that one off then?
Rosemary, can you turn that one off, please? You have to turn that one off.
Sorry, did we,
No, it's not on.
It's not on, Rosemary. Can you put it on, please?
There we are.
dentistry, we've had a go at dentistry,
We have.
but there has been indication from government that that is changing. Could we put that on for later on?
We could put it for later on, but I think we are a bit premature. I've already been finding out that there is programmes in place at the moment about dentistry. What I don't want to do is have something that we've only just looked at. I think it would be really good. Give them an opportunity to see. We need to give that that cycle of event really. And I think we might just be, we might not might be bringing anything new to the table at this present time. It wasn't very long ago we had it. Councillor Bruce.
Thank you, Chair. I've noted that on the work programme, we only have dates up until April, which I assume has got something to do with discussions around the structure of scrutiny going forward and proposed savings, etc. I just want to, if possible, if you'll allow me the indulgence to make a statement that I'm very concerned about the idea that scrutiny might be reduced. We have always had very, very full agendas, especially on this scrutiny committee. There's so much to look at. I really do hope that we will not be in a position where we have reduced scrutiny meetings, but forgive me for that little bit of indulgence.
Okay, if I can come back to you on that, we've made that very clear at the executive yesterday. We made it very clear at the 2 scrutiny meetings, which I know you were at, one of them at least. We've made that very clear. The importance of scrutiny is to scrutinise. This is a massive council, and I think you're absolutely right. And I think both the deputy and I, we both feel very strongly, we'll make that point again and again, that the scrutinies, I can see the logic, I can see the savings that they wanted to do, but this is the whole point of scrutiny, is where we ensure that we are doing the job for our communities out there. And we are fighting for that. And I do think, I have to say, I was at the executive yesterday and I think they've listened to us. I haven't got the clarification, but I think we're okay. What we've not done, what we've done is we put major things in, okay? And then what we'll do is we'll get them, because as far as I'm concerned, we are business as usual. So we will actually clarify those points. It's about us picking up the major areas at the moment. And then what we'll do is we'll put so many in each meeting. So we're not overloaded, and we give the presenters enough time to come and present and us enough time to ask questions. When we have a very packed agenda, what happens is we're running time is short, and then we don't give the presenters enough time. So if you're happy with that idea, I'll be very pleased. Thank you. Councillor Ashton, sorry.
Yeah, just to take that point one stage further, a lot of the restructuring of the scrutiny committees was shelved at the executive state. And the size of the scrutiny committees was handed back to the chairs of scrutineers to decide. So I think that a lot of the fears have been turned out to be groundless now.
The issue is that everything has to be ratified at the full council. So the thing for us is why I'm always a little bit cautious, but I think as well, the numbers on scrutiny, I think today demonstrates why if you reduce the numbers down, many members can't always get certain dates. They can't get to geographically to the areas. So sometimes I think what we feel is that the amount needed on scrutiny does cover. So if you're happy with the numbers that are on this community, this scrutiny committee, if you're all happy with that, we would echo that we want the same number and the same amount on our meetings to carry on in the same way. Or well, the only thing is, I will say this, we have to think about our admin staff as well. There is a point of view about having more meetings. What happens then is you don't get the information in enough time. You don't get the people to book the meetings in. Admin have to do the work. They have to get the people here. So sometimes 6 to 8 weeks may sound not great, but in some respects, I'd rather have a meeting where we're fulfilled with full information in than having somebody come here that hasn't had the time to bring it. So there is 2 schools of thought there. I think we need to be a little bit mindful about that. But I do enjoy seeing you, so,
Councillor Sully.
Councillor Sally.
Thank you, Chair. I recently attended a mental health network conference in Bridgewater, and it was attended by all the VCSE groups, well, most of the VCSE groups across Somerset coming together. I think I may have been the only sort of potential policy maker involved in policies development in that room, and it seems really important that we have those links with those grassroots groups as mental health, strong communities is integral. Looking at the work programme, although when we first started our scrutiny committee, it was quite strong our links with the VCSE sector and mental health provision and what they're doing. And I just wondered if we could bring that bridge back and maybe, still consult with those groups or bring those groups in to tell us what is going on the ground, and as it's a really important part of our delivery of mental health services, and to support what they're doing. So could we bring that back onto the work programme? Obviously, I'm not giving you a detail, but it was Spark, obviously Spark Somerset. So whether we can get them in on the list at the bottom of the work programme. Thank you.
Well, it's very relevant because on the scrutiny meetings I've spoke, as you know, the budgets have been reduced in certain areas. I cannot believe that they're reduced in mental health and substance abuse. I fought for that again yesterday. I'm probably driving them mad because I keep bringing the same things up. But I think this is very relevant, and I think, yes, we should have this on the agenda. And I'm sorry that I couldn't attend the one in Bridgewater. And if it's Bridgewater, how awful is that? But I had my own fireworks going on, as you know. But I hope that when they come here, we can or come to the next scrutiny committee or as quickly as they can. I think this is a very, very important issue at the moment, and especially in light of the media recently, the issues here with the media that we've been hearing about mental health, attributing to lots of awful antisocial behaviour. So I think it is relevant. I think it is important, and yes, we'll put that on the list. Thank you.
Just a quick comeback to clarify. So Spark Somerset will be invited in to talk about their work across mental health across Somerset. So that's what is that what you're? Can we clarify that?
It would be Spark, or it could be somebody from the mental health team.
Yeah.
I mean, I think we have to see what we can do. But I think as long as we got it on the agenda, welcome Mel. I think that would be great. Okay. Hilary, sorry, Councillor Bruce, sorry.
Thank you, Chair. Is it possible? I know that we do have sort of annual reports. I think mental health services is one that would be a good candidate for coming back to us every year. Is it possible to add to the bottom of the work programme a list of what we get in terms of reports annually, and some kind of tick box really? Have we had that, and we've got to have that still, where that's going to come in, or even just a list of what annual reports we receive? So when we know actually, then when we look at the work programme, we know that's going to be covered at some point anyway, because it comes to us once a year.
Yes, just a sort of a programme of events, really. What we want to do is a programme of our work, really. I think that'd be good. On the annual budget in May, which I will present with every detail on. But I think that would be really good to know, because sometimes we think we've done this a little bit of time ago, and then we realise actually we didn't. So I think we can ask Jenny to do that for us, because I know she'll love that and she'll like that very much, and she'll appreciate you asking that. Thank you very much. Thank you. Okay.
We've got a hand up online of Councillor Wade.
Oh, Councillor Wade.
Wade.
Councillor Wade, I do apologise.
Yes, good morning, and well, thank you for hearing me. I was looking at the work programme. I was going to substitute, then Steve very kindly stepped in, so I'm glad about that. But I note something very close to being topical and close to many of our hearts is cancer, and particularly aftercare and groups, and which well, some of us attend. And I just wonder if that is something should be on the work programme in some way or other.
Thank you, Councillor. Well, what we need to be is very specific on this scrutiny. We need to not just be scrutinising areas we need to be actually specific on what area. So are you actually saying that we should be scrutinising aftercare, cancer health?
Well, yes.
Yeah,
because there is various ad hoc groups I know of, and of course the hospital have some sort of follow up. Obviously, I just wonder if it was something which could be scrutinised. I'm not sure it could be, but I'm just asking the question, Chairman.
Thank you. I think at the moment, with a lot of the aftercare, cancer treatment is very, very well cared, but maybe Mel would like to, I'm sure she'd love to come in at this point. Thank you.
No problem. I think it's about understanding what's out there in the community, and we do have our village, our community agents, our talking cafes. If you go to those areas, they'll be able to tell you what's in your local area. It's far more difficult for us to scrutinise that here. So I think that'd be really difficult, but I think if you want information and advice, we can make sure you've got that information and advice and know where you can get stuff from and where there is places that you can go and see. So it's probably a better way to look at it in that space, and we can do that for you. We can give you that information outside this meeting.
Thank you. Are you happy with that, councillor Well? Is that okay?
Yes, thank you. Thank you very much, Chairman. Yeah, thank you.
Thank you. And nice to see you. Even I prefer to see you in the face, but nice to see you online. Thank you.
Yeah, thanks. And your good self back again. Yeah.
Thank you. Thank you. Councillor Lawrence, please.
Good morning, and lovely to be on my way back. It's taking a while, and I can absolutely say there is a vast amount of support for people with cancer. I'm so impressed that every time I've had to turn a corner, and I've turned a few corners in the last 6 months, I've had support coming and available to me. So much as I'm sorry that you can't all know about how much support there is, and I hope you don't need to know, because you don't need that support, but I can absolutely tell you it's been absolutely amazing. There is an awful lot of people out there willing to spend time and help you, whatever types of cancer you might have. So be assured there is a terrific amount going on in the background when you need it. Thank you.
Well, Councillor Lawrence, can we just welcome you, Christine? It's lovely to see you. You've done so well.
Thank you.
I can say, it's probably many in the room. I also am on the Cancer Club. Have been. My husband's in the Cancer Club at the moment, and tremendous amount of work's being done. But it is a journey, and I think if we can give information locally to people so they know what's out there, I think that will be very, very helpful. But look forward to seeing you next time.
Thank you.
Thank you. Councillor Wale, is this a legacy, or you still want me?
I know, I was just going to add, I'm in the same boat as, or have been, as Christine, and I'm fully supported, I must say, by Beacon Centre, Musgrove, etc. And but it just occurred to me that the aftercare section is very localised, and that was all. And I agree with what you say. I agree with what Mel says, and I'm also very glad to see Christine back, because I had to substitute for her some time, and so I've got out of that job. But anyway, no, that's all. Thank you, Chairman. Thank you.
Lovely, that's very kind. Thank you very much.
No.
Councillor Bailey.
Thank you, Chair. Are we trying to, just following on from what Mel said, trying to get a handle on where there are gaps in the service support here? I'm not quite sure what the question is intended to elicit. That would be very interesting, because obviously we've got two examples of where they've been really well served. That because it's out in the community and dealt with in the community, are there gaps that aren't served that we need to be thinking of? That's really what I want to clarify, please. Thank you, Chair.
Mel, would you like to?
And I think that's something that we can talk to the ICB about. I think that's their bag in essence, but we can have a conversation with them about, okay. And it may be when they bring their performance report here, you can put that as an add-on, which says actually, where are you? Because they will talk about cancer, they will talk about delays, they'll talk about where they're hitting the targets. What you may want to talk about with them is say, ask them at the same time when they do their performance report here, can you think about the aftercare as well? Is that well done? Do you think there are gaps in service? And again, I think that's probably a conversation that we can have with the ICB.
That's very good. Thank you very much. Okay, right. Well, I think that we've done that very, very well. Obviously, members, if there are specific issues in your areas, or something comes up that you think really does need, by all means, send in to us, and I'd be really interested to have a look at and see where there is something we can look at. Okay, item 6 is a Healthy Western, and I'm going to invite Judith Hernandez Di Pino, I hope I've done that right, and Elaine Elderstein, Helen, Elderstein, to present, please. Sorry, I hope I'm probably pronounced those totally wrong, but welcome.
You did a good job. It's Judith Hernandez. That's much easier.
Hi, and I'm Helen Edelstein. Sorry, they're not the easiest of names, are they?
We're just going to adjust the sound a minute. We can't quite hear you very well.
I don't know why it's just.
Our owl is playing up this morning.
Speak.
Hello.
Is that any better?
Oh, that's much better.
Great.
Again.
You okay? Everybody good?
I can hear it.
Should we kick off?
Is it not going to turn for the presentation? Is it going to take the presentation? Are they going to present?
They'll have to present themselves. I don't have.
Oh, yeah, you're going to present. You're going to present, aren't you? Yes?
Yeah, we are. That's fine. I'm happy to.
Lovely, thank you. Yeah, we're good now. Thank you.
Great. Should we quickly introduce ourselves, and then I'll run through the presentation, and then we'll have some time afterwards for questions, if that's okay. So I'm Helen Edelstein, head of project development at Bristol, North Somerset and South Gloucestershire ICB.
Hi everybody, my name's Judith Hernandez and I'm the hospital director here at Western General Hospital.
And the purpose of today is just to give you an update on the Healthy Western programme, which is a joint programme between the ICB in Bristol and also University Hospital Bristol and Western. So great, so I've just got some slides that I will flick on, and we won't take too long on the slides because I know that you should have received them as part of your paper packs, and we'll have some opportunities for questions at the end. So can you see those slides okay?
Yes, thank you.
Yes, thank you. Thank you.
Great.
Make them slightly bigger. Could you just make them slightly bigger, please?
Yes, of course.
That'd be really helpful.
Is that better?
Lovely.
Brilliant. So the purpose of today is really just to talk to you about our vision for wellbeing, health and care in Western, with a particular focus on Western General Hospital, and to describe some of the plans that we've got to make sure that Western Hospital is sustainable at the heart of the community and provides services that meet local population need, both now and moving into the future. We want to tell you a little bit about some of the things that we've already done and how well they're doing and some of the successes that we've already had. And then also just to emphasise how we're working in partnership with primary and community care, but also your colleagues within Somerset ICB and also Musgrave Hospital. So our vision for Healthy Western, which was developed in 2017 as part of the first programme, Healthy Western 1, which was primarily around addressing or making improvements and addressing some safety concerns related to the Accident and Emergency Department at Western General Hospital. But Healthy Western 2 vision is for Western General Hospital to be a strong and dynamic hospital at the heart of a community that's fit for the future, with a range of services providing the very best care, experience, safety and outcomes to local people. So Healthy Western Phase 1 has been delivered, and we've made changes to the Accident and Emergency Department within Western General Hospital, and that's been hugely successful, and we've seen some improvements as a result of that. We've now moved on to Healthy Western 2, which is about the long-term sustainable future of the hospital. And we've divided Healthy Western 2 into 3 core parts. So the first part is same-day emergency care, so enhancing the services that we provide within the Accident and Emergency Department to make sure that they're in line with the long-term plan, the NHS long-term plan, but also in line with services provided in other accident and emergency departments across the country. It's about introducing a 72-hour acute monitoring unit, so providing short stay care for non-frail adults, but also introducing a 72-hour older people's assessment unit and a geriatric emergency medicine service, recognising the proportion of older people that need specialist care within the hospital and really kind of tailoring care to meet their needs. Phase 2 is primarily focused on inpatient care. So again, we're kind of reframing the way we provide inpatient care within the hospital to really kind of tailor to meet the need of older frail patients. So providing lots more holistic person-centred care, excuse me, that recognises the needs of the whole person as opposed to it being about single diagnosis of a particular condition. We're also making some changes to some medical inpatient pathways to make sure that the people of Western and our catchment beyond have access to specialist acute medical care from some of the big hospitals that kind of surround us, so the BRI, North Bristol Trust and also Musgrave. I should say that about 20% of Western's attendance is from people from Somerset, so around 20% of the people that we see and treat are from the north of the Somerset district. And then finally, the phase 3 of the programme is about kind of creating a centre of surgical excellence, so providing lots more planned care locally within Western General Hospital to meet local people's needs and kind of reducing some of their travel. So, for example, that may include things like ophthalmology. So how can we provide more ophthalmology within Western that kind of reduces the need to travel? But that's just an example of some of the things that we might do. We still need to work through some of the detail. So in terms of this slide just kind of sets out the 3 core parts that I've just described. So we're making changes to inpatient medicine. We're enhancing same-day emergency care so that people get their treatment quickly and can go home quickly. We're introducing more planned surgery and creating a specialist centre for the care of the elderly. But there's lots of other services within the hospital that will stay as they are and will continue to improve as they are now. So we will still continue to provide children's services. We'll still continue to provide maternity care. None of that is changing. It's just that we're particularly strengthening and enhancing 4 core parts or 4 core service areas within the hospital. This slide just sets out the reasons for the change, the reasons why we're doing this, and the reason for Healthy Western too. And I've talked a little bit about this already. So we know the population is growing and has new healthcare needs, and the plans include services for all ages. We'll keep A&E, maternity, children's services as they are now, but we'll have more care for older people and more same-day emergency care so that people can get home quickly. We need to make sure that the service is safe and stable. The plans that we're introducing means that there are enough staff to make sure the hospital services meet local and national standards now and in the future. So we're enhancing the number of people within our teams to make sure that we can have stable, resilient workforce within the hospital. We know that we need to work better together with primary and community care so that we create kind of seamless pathways both into and out of the hospital. And these plans are very much being developed in partnership with primary and community care and build on the merger between Western and Bristol Trust. And then this final point is around we need to make sure that we're using resources well. So these plans are really about making sure that the hospital is financially sustainable in the future, but also can deliver the very best care and outcomes for local people. I just wanted to draw your attention in terms of the public engagement, staff and local stakeholders that we've done over the last few years. So we've done quite a significant engagement, including a public engagement event that we ran in the summer of 2022 and involved invited people from across BNSSG, but also Somerset too. So over 5,000 patients, public and staff have helped shape these plans and to keep Western General Hospital strong for a long time. We've also involved clinicians in the development of the plans, so they've very much been clinically led, making sure they're very much involved with planning for the future and for the improvements. And we've got a commitment to continue to engage with the public staff and local stakeholders. And we've got 2 patient public representatives that sit on the Healthy Western programme group, and they've been absolutely invaluable in terms of directing and helping us to shape the plans that we're developing. We also work quite closely with Healthwatch, so we've got a Healthwatch representative too on our steering group, and again they've been feeding some specific input in terms of the work that we're doing as it develops. So I just wanted to talk a little bit about the strides that we're taking to implement our plans, and this at the moment is very much focused on phase 1, which is about enhancing same-day emergency care and short-stay provision within the hospital. And I'll ask Judith to jump in at any point because she'll be incredibly familiar with a lot of the detail. So as part of a business case that was agreed in April last year, we've been on a journey to implement and enhance services within our accident emergency staff. So we've appointed around 32 people across our range of roles to work in our ED. We now have more same-day care and short-stay provision, providing high-quality treatment, care faster and with shorter stays in hospital. And we've also got specialist holistic care for older people in emergency, and that's our geriatric emergency medicine service, but also an assessment unit, a short-stay unit for older, frail patients. Alongside these plans, we're also developing our Seashore Centre, which is our children's centre. providing paediatric expertise to the ED, and also providing more urgent treatment and specialist clinics for children. And new transfer of care hubs is linking services across Weston to speed up the discharge process and make sure that more people get the support they need when they leave hospital. And again, we're attracting and retaining more staff, and I know our vacancy rates are something to be incredibly proud of at the moment. I'm sure Judith will pick that up in a second. So in terms of performance, this slide just gives a bit of a snapshot of, as a result of that change, we're making a real difference to the quality and safety of the provision within our accident emergency department. So significantly more patients have had their care managed swiftly and skillfully, with most people not needing to be admitted. So we've managed to treat and assess many more people as part of our same-day care provision, so that we reduce the need for people to be admitted. We've made improvements to quality and safety, and there's an example here to demonstrate that. So in December 2022, which is generally one of the busiest points in the calendar for accident emergency departments, there were 9 occasions when ambulances had to divert away from Weston General Hospital because it was just too busy. In 2023, as a result of some of the enhancements that we've introduced, there's just been 3 ambulance diverts in the whole of the year to date. So quite a significant improvement in ambulance diverts. There's been month-on-month improvements in waiting times and the number of people waiting in the emergency department. And as I mentioned, there's been a significant reduction in our staff vacancy rates. The vacancy rate for both nurses and doctors are below the 5% target, compared to 19% nursing and 7.5% medical in 21-22. So quite a significant difference, really demonstrating that we're attracting staff, but also keeping them too. And I know, Judith, we've had some really positive feedback, haven't we, as part of staff surveys around kind of morale and how how people feel working within the hospital. That's been incredibly positive to see.
Yeah.
So what's planned next? So this is the plans that we're working on at the moment. So we're moving into phase 2 of Healthy Weston 2, which is about improvements to care of the older people. So meeting their complex healthcare needs in an environment that best suits their specific needs. This includes clinics for quick diagnosis and improvements to how we work together to deliver good integrated care. It also means that anyone who needs to stay in the hospital longer than 72 hours for specialist medical care will be taken to a neighbouring hospital for the very best care, making sure that there is equity of access for the people of Weston and the wider catchment area to specialist care within the neighbouring hospitals. And then phase 3, which we'll move on to probably at some point in the next year, is around the surgical centre, which is about how we introduce more planned operations within Weston General Hospital, and making sure that it's a surgical hub providing operations for people of all ages close to home, include e.g. hip, knee and cataract surgery. So this slide has been included because it was something that came up as part of the public engagement. People were a little bit worried about having to travel more or less for their care. And we just really want to make the point that more people will have operations at Weston General Hospital, so they won't need to travel elsewhere for operations or appointments before and after. But each day around 6 people will transfer to a different hospital for specialist care if they need to be in hospital longer than 72 hours. We haven't quite got a date yet in terms of when that will be implemented. That's likely to be over the next year to 2 years, but this is really about making sure that people have equity of access to the very best care, and as a result better outcomes. However, we recognise the impact of travel may have on people, and we're thinking through ways, working with our patient representatives to develop solutions to how we might lessen the impact, such as things like more virtual enabling people access to Wi-Fi and being able to call their loved ones, but also our charities have recently introduced a bus as well between the hospitals. And then just really a few kind of closing remarks. So We feel that we're taking great strides towards our vision for health and care in Weston. We are transforming urgent and care for people of all ages and helping to get them home quickly after an emergency. Our Seashore Centre, our Children's Centre, is now open longer and providing specialist paediatric advice in emergency. And our new transferring care hubs are linking services across Weston to speed up discharge and make sure people have the care they need. But there's still more to do, and those are the plans that we've just described in terms of care of the elderly and our ambitions for a surgical centre, and that's where I just want to finish. I don't know, Judith, if there's anything that you want to add.
No, nothing to add at this point, but very, very happy to take questions.
Thank you very much. Thank you. That was very enlightening, and obviously it's really good for us to know what's going on in Weston. So members in the room first, do we have any questions? Councillor Bruce.
Thank you, Chair. Thank you very much for the presentation. Very interesting. I have to say your figures in terms of the staff vacancies is very, very encouraging. That sounds like a success. I'd be interested know what you attribute that success to, and you say about how those figures compare to figures, I'm assuming, in Weston in 21-22. How do they compare across Somerset and nationally as well? Are you significantly performing better than other areas? So that's the first question. And if I may, another question as well. You say that patients can return to Weston after getting specialist care elsewhere. I'd be interested to know how many patients do that and how the impact of that is being measured. Thank you.
So shall I just take the recruitment question first? So we're currently in line with the national average or within the national kind of target in terms of that recruitment target. And in fact, from a nurse perspective, the kind of best site in UHBW in terms of that recruitment. We did have a big focus on internationally educated nurses, and but of course retention is as critical as recruitment. So our retention is also about the best in the trust currently as it stands. So we're now being able to attract people, and they're staying. The medical recruitment was a big challenge historically at Weston, and the hospital had a very high proportion of doctors that were not substantively employed but were there on locum kind of arrangements, and that's slow and steady in terms of its improvement. But we've had great success at attracting a very, very good care of the elderly geriatrician consultant from the other side of the country, who'll be starting with us in a couple of months. And again, within our emergency department, we've made 3 great external appointments of substantive consultants. So we're turning the ship in terms of the medical recruitment. There are some national posts that are very hard to recruit into. Acute medical consultants are a difficult workforce. Radiology consultants, difficult workforce to recruit to. So we're finding ourselves now, rather than being a complete outlier in terms of medical recruitment, we're finding ourselves kind of falling into line with some of the national challenges, rather than the national challenge plus a Western challenge. Does that help around the recruitment?
Yes, it does. Thank you.
Thank you. Sorry, Karen.
Sorry, and the next point. You need to remind me. Sorry.
Yeah, sorry. It was about the number of patients who actually do return to Weston for ongoing care after they've gone somewhere else for specialist care.
So patients are. It's a slightly crude term in terms of repatriated, but where they need to be. So sometimes if they've gone to other centres for specialist care and have recovered enough to go home, they'll go home. So it's not an automatic pathway that they necessarily need to come back to the hospital. But if they do need to come back to the hospital to carry on with their ongoing kind of care needs, that already happens. And again, we anticipate, and certainly certainly in terms of how we manage our bed base and will manage our bed base in future, make sure that we've got enough space to manage a proportion of patients that will need to come back to us for ongoing care.
Thank you, very interesting, thank you.
Thank you very much, Kat. I've got while everybody's waiting, sorry, well, I've got a couple of, I'll go in between, I'm a bit naughty, but I'll go in between. I've got a couple of questions here on phase 3. You mentioned about the plans to work for the surgical, works on the way for the surgical hub. So I'd like to ask about that, please. You can answer that. I've got to cut 3. So if you want to answer that one first.
Yep, sure. So as part of the whole phasing of Healthy Western 2, so the final kind of phase is absolutely about that surgical centre of excellence. This is about again ensuring, and the focus was really on high volume, low complexity surgery, and that being that Western would be developed in terms of the system hub for that kind of surgery. So we at the moment are doing some very long and complicated mapping with our partners within the system, including at Musgrove and at North Bristol Trust, as well as internally at UHBW, about how we develop that approach and the best place in order to manage the care needs of both the local patients at Western, but actually that centre of excellence, meaning that patients within the system have got a clearly marked place to go that provides excellent care and is recognised as such. The details about that are still being worked through, but the kind of reflection about the high volume, low complexity still is what we're working through the detail of at the moment.
Well, thank you for that. Obviously, I think that would be a tremendous help when that is in place, and it would be really good for you to come back to us and let us know what the situation is and how well it's progressing. Thank you. 2022, you did a 5,000 public engagement. What are you doing now to engage with the public, to let them know that Healthy Western is a Healthy Western? It's not a hospital that was going to be closed and all the bad press about it. Because I think it's a really important issue that members of the public need to know that this hospital, there is a change. And I just wondered, what is your programme of that, please?
Yeah, so you're right, and I think we're not always very good at the success story stuff. So actually, we do now develop a series of stakeholder updates, which we take out into the system. We work very closely with colleagues in primary care, certainly peer health in Western, but have reflected, having talking to the clinical leads in the Woodspring catchment locality, that actually we really need to be pushing ourselves out further into the system, so that through those primary care networks particularly, GPs have got the opportunity to see what's happening in Western, to see the changes, and to be able to understand where the pathways now may mean that their patients don't have to travel into Bristol or to North Bristol or indeed to Musgrove. So we've got further work to do on that. It tends to be more through the health network rather than the Western Mercury as such. But we are developing that stakeholder kind of approach as we go, and that includes us going to the primary care network meetings, etc.
It's always a good thing to remember that bad news travels fast, good news takes much longer.
I know.
Yeah. Councillor Bailey, please.
Thank you, Chair, and thank you for your presentation. It was excellent and very positive. You must be very pleased with the direction of travel. Just a couple of questions. One's a clarification. With acute stroke, bearing in mind what we were talking about earlier on, who do you refer to? Is that Musgrove or is it to Bristol?
No, it's to so there was a slight separation in as much as acute stroke predominantly goes to North Bristol Trust as part of that BNSSG stroke transformation. As part of the business case for that, a very small proportion of patients that had come to Western now go to Musgrove, but that was really picking up that north of Somerset border. So yeah, but a very small amount, predominantly North Bristol Trust. And then, of course, Western retains the stroke rehabilitation. So those patients tend to come back to us.
Thank you. My second question is back to recruitment, really, and retention. You must have reduced locum costs, I'd imagine, with the 5% target that you reached. Do you have a figure for that sort of payback? Perhaps not the right word, but advantage.
Yeah, I haven't got the precise figure off the top of my head, but we have made savings, yes, absolutely. And part of the business case almost around the Healthy Western investments was that we would see some of the savings drop out of that as we turned the tide in terms of the high agency use, whether that be across locum or nursing, and converted that to substantive sustainable workforce.
Okay, thank you very much.
Thank you very much. Anybody? Oh, so now we're out of the room and we're to Councillor Lawrence.
Thank you. Thank you very much for that wonderful display of what you're doing in Western, because I was not aware of you doing so much, but it's a really clear report and very easy to read. And one of the problems I've picked up with people as I've been traveling about hospitals, and I've used quite a few, is transport gets it. People find that the difficulty. It's not the hospital at all, and there's nothing you can do about that. But I think as a county councillor, we are more and more aware that this can be making it extremely difficult for people, and it's a very difficult thing to deal with. But I'm very impressed when neighbourhood hospitals can actually help you quicker sometimes than your local hospital. It might mean you've got to travel a bit further, but actually time-wise, when you get there, it's a bit simpler. And I think that's a wonderful way that the NHS are beginning to use their facilities in a much broader way, so that those long queues are being reduced and reduced quickly, because sometimes it's very distressing to be waiting for months and months and months, when actually for the sake of an extra 2 hours journey you could have been seen much quicker. So I think anything that helps people to feel looked after quickly is excellent. So thank you all very much.
Thank you.
No question.
No, thank you
for the question, Councillor Lawrence, but I didn't get one. Never mind. Well, I'd like to thank you for today. Thank you for your presentation. It is always really good news to hear a hospital is changing the way that it's been perceived. And I think my summing up here on this would be, I think we need to find out the public arrangements with the media and public engagement of how successful you are. I think you need to do, I would ask you to do more work on that, and perhaps let us know how that's going, because I think honestly it's really, really important. The surgical hub program as well, I'd like to know how that's going and what is the end result, and what are you achieving, and if you have achieved what you want. Does anybody else want anything added to that? I think I've picked up on. I think the other questions were answered, but what we'd like is perhaps for you to come back to us, if that's okay, and give us feedback again. It'd be nice to keep the loop, keep in with you, keep that contact with you to know how things are going. So that we in turn can talk about Western as being Western as one of the main hospitals as well, because it's something that Somerset Council needs to do, and it doesn't necessarily happen now. This is a good start, and I think progress is being made, so we are very, very grateful to you. So thank you for today's presentation.
Thank you very much for having us, and we'd be delighted.
Thanks very much.
Thank you.
Thank you.
Thank you. All right, members, item 7 is the annual report from the Director of Public Health, and we're going to invite Alice Munro, easier name for me to be able to say, Alice Munro, to present, please.
Hello, can you see my screen all right there?
Yes, we can. Yes, thank you.
Lovely. Thanks. I'm Alice Munro, consultant in public health. Sorry not to be there in person. I've just got a winter bug, and I thought you probably wouldn't want me in the room with you. But hopefully I can do justice to the report remotely.
We appreciate that very much.
So I'm just here to report on the annual Director of Public Health report this year. So the report is a statutory duty that all Directors of Public Health need to perform each year. It's an independent and personal view from the DPH that looks at the evidence on a public health topic that is often outside of business as usual. So it's usually about issues whose profile needs to be raised and where there's a role for the local authority and the health and social care system to respond collectively. I'll give a headline overview of the topics being covered and the recommendations being made in this year's report, but the final draft of the report will be circulated ahead of the Exec Committee in March. The theme of this year's report is homes and health, and in a positive light, it's really clear from all the evidence around homes and health that homes provide a strong and essential foundation for good health. So when people live in stable, affordable, decent quality homes that are suitable for their needs, it goes a really long way to ensuring that they can live healthy, independent lives for as long as possible. Two major themes of this year's report are that when people live in poor quality or unstable homes, and those things often coincide, then this is a driver of poor health and of inequalities in health between more and less deprived communities. And that can be due both to direct health effects of living with hazards like damp and mould, and indirectly with the effects on physical and mental health from the stress and insecurity of living in a poor, unstable home, and also if it means people don't have the disposable income for other essentials. Then a second major theme of this year's report is that we have increasing numbers in Somerset of older single-person households and very underoccupied homes. So over half of homes in the county are very underoccupied in the latest census, meaning that they have 2 or more spare bedrooms. But this coincides with a large number of young adults and young families seeking social housing due to a shortage of affordable housing. So what we're seeing is not so much that we have a material shortage of homes, but we have a shortage of the right kind of homes in the right places. So things like accessible 1 to 2 bedroom homes that people can downsize to, and a shortage of homes in more urban areas that are suitable for young adults and young families. So a little more detail on some of the themes around affordable and stable homes. As I'm sure you're all very aware, housing is very expensive in Somerset. It's more expensive than average for England relative to local incomes. It's over 9 times average incomes in some parts of the county, which obviously has consequences for average income as well as low income households. In consequence, nearly 1 in 5 households are now living in the private rental sector. We have more in the private rental than the social rented sector. And we have good evidence from elsewhere, not local evidence, that insecurity, if people live long term in the private rental sector, and being in the private rental sector means there's a higher chance their home will be non-decent. The long-term health impacts of that can be comparable to smoking or unemployment. At the sharp end of the housing crisis, then this means that we're less able to meet the needs of people who've experienced multiple disadvantage and have complex needs, maybe multiple health conditions and disability, and who are more at risk of becoming homeless. We know that the typical person applying for social housing in Somerset is a young adult, usually under 35, often with 1 or more health or care needs, and yet only a minority of them will be prioritised to get a home. So we recognise, obviously, it's a very challenging time to find solutions, but the recommendations in the report include to grasp the opportunities that are created from going through a transformation process and from developing the new local plan for Somerset. And they include that the local plan should consider health needs and demographic trends in the county and the type of homes that we need as a result of those. So we need to use the local plan as a vehicle to innovate and find ways to develop more 1 and 2 bedroom homes that people can live in and age in. And further to that, we need to prioritise collaborative work to address the needs of people who experience multiple disadvantage. And we've got strong work to build on there, from programmes like Making Every Adult Matter and the Homeless Health Service. And those programmes are sort of outlined in more detail in the report. A further theme then is around the quality and suitability of homes. And those are the first 2 points on this slide are related, that many homes in the county are not energy efficient, and poor efficiency or not being able to afford heating contribute to damp and mould and cold homes. The most vulnerable groups in terms of the health impacts are young children, older adults and people with some long-term illnesses. And those groups are also at risk from physical hazards in the home that can contribute to falls and to child unintentional injury, which we have higher rates of in the county. So we have several examples of effective interventions to address those issues in Somerset. Those include the independent living centres, where people can go and test out equipment that can help them maintain their independence, housing adaptations, in-home support from Somerset Independence Plus, and support for energy efficiency measures from the Safe Warm Somerset helpline. Another example is the complex care team in South Somerset. That's a small team of health and social care professionals who meet and assess all the health and care needs of individuals who are waiting for a care assessment in the area, whether they'll then support interventions like installing a grab rail, helping them access grants, or reducing the number of medicines they take, sort of really taking a person-centred view of the whole person and addressing a multiplicity of needs rather than just a single pathway. And they've really successfully reduced waiting times for care assessments and the risk of hospital admissions for older adults in their area quite significantly. So the recommendations under this theme include that the ICB should continue to provide support for retrofit interventions and housing adaptations that allow people to live safely in their homes, and that they seek to expand approaches like personalised care for people to stay safe and well in their homes. The final theme is the neighbourhood that people are living, so the places surrounding our homes, because there's very good evidence that how places are designed plays a major role in enabling people to lead healthy, independent lives. So things like access to public transport, walking and cycling routes, green space, safety by design, interventions, access to local amenities and shops and services all contribute to how resilient and connected our communities are, and therefore in turn to how well people can look after their physical and mental health. Alongside this, though, flooding is having increasing impacts on housing in Somerset, and that has major implications for how we design our homes and where they're built. So the final recommendations of the report relate to the place surrounding homes, and that the council embed health and how we design healthy neighbourhoods when developing both the new local plan and the transport plan, and that we seek to design neighbourhoods that improve health and support community resilience and reduce the risks from and the impacts of climate change in Somerset. So that just gives you a really headline overview of the topics covered in the report, and obviously more detail will be in the report itself, which will be available in a couple of weeks ahead of exec, but I'm happy to take any questions for now.
Thank you very much, Alice. Thank you. Can I ask members first if we have any questions for Alice, please? Councillor Bailey.
Thank you, Chair. Thank you for that excellent report and for dragging yourself from your sick bed.
Could you put your microphone a bit nearer, please? Sorry.
Sorry, thank you for that report, Alice, and for dragging yourself from your sick bed to give it. It was excellent. What I'm sort of thinking about is what we actually do with the report's findings, because obviously there's a lot of interconnected thinking there in terms of housing, type of housing, and I'm just trying to scratch my head and think, well, yeah, that's what we understand already, but what do we actually do? What does this scrutiny committee do, and what do we do as councillors in terms of addressing it? Because I can see those same things occurring in 2 or 3 years down the line, unless we actually find some plan to move forward on that. That may be part of your report, which we've yet to see, but that's my concern about what do we do next. Thank you.
Do you want to answer that, Alice, or do you want to wait for the report?
Well, the repair recommendations in the report will relate to different audiences, and there are tangible recommendations that we can look at the powers that we do have, particularly with an emphasis on the local plan and the transport plan as levers for influence in terms of the future homes that we build. And the recommendations are aimed at different audiences as appropriate. They will be in the final report in more detail if you're happy to wait for those.
Yes, I am. Will that report come to us for discussion? Or we'll just go straight to exec?
It goes to the exec, so it'll be part of us to make sure that we take those reports. Okay, but you're absolutely right. We do want to make sure that when we're bringing up issues, when we're scrutinising, then actually there is a worthy cause to do this so that it makes some difference. So that is important that that's always kept above. So can I go to Councillor Woods, please?
Yeah, thank you for that. I've always understood the need for healthy homes, but I'm surprised when I help people locally that some of the things I assumed, oh, that was always a home that provided healthcare. It had the add-ons. They were places that we had for our social housing that used to provide meals, backup, all the rest. But that seems to have disappeared a bit. And that is a concern when we see elderly people being discharged from hospital back to a care home that we think, oh, that's all right, but it doesn't provide all the things they used to. Now, is that something you find with care, that people are discharged, but the facilities that used to be there aren't there anymore?
Alice, would you like to, or Mel? I'm sorry, Mel was going to take this. Thank you very much.
Are we to take it, Alice?
Yeah.
So there's a range of, I think what you're talking about is perhaps some of the supported housing models that have been about for many years. And there's a variety of those supported housing models. But what we would always do if somebody was leaving hospital is just check what their needs were and what was available. Some of those homes used to be perhaps sheltered accommodation where you had a warden.
Yeah.
Clearly that isn't there anymore. But actually there are other forms of getting support in to a family or to a person when they go home. So what we'd normally do is have a look at what they are. That doesn't mean to say those housing solutions, because often we're finding it was only needed for one person in there, not for everybody. Therefore, it wasn't working in that space. However, our extra care housing model, that does have more support in it. And that can be 24-hour support, but we also can enhance that. So there's normally a core support model that we can then, if somebody requires that and has Care Act eligible needs, we can then go and support that. However, if the person is perhaps a self-funder themselves, we can also work with them to say, actually, what else what is out there that you may want to buy yourself. So there's lots of different models, but actually it is very individual. We work with the individual in those spaces.
Okay, can I just, Mel, I'm sorry, just come back to you, Mel, if I may. I just recently, in my walk, it's a bit parochial, but I recently experienced an elderly man who's mentally absolutely amazing, physically not good, sent out of hospital. They misunderstood that he had a nephew who was full-time working, so they misunderstood that. They sent him home. He wasn't home for a few days. He could not cope at all. There was no backup whatsoever. And well, no, that's not true. He had a week's backup, and we thought he meant 6 weeks. He didn't, he had a week. After the week was over, I actually realised I hadn't seen him, went across to him. He was in a very bad way. I got an ambulance and got him back in hospital, which he's still there now. And what I'm saying is, what efforts are being made, why people are in hospital, to come out of hospital, to assure that they are given the care they need. And I'm talking about either private self-funding or whatever. He was never asked that question, and that's the worrying thing for me, that people go into hospital and then come home and they're expected to cope and they can't, which is very similar to what Councillor Woods is saying.
There are two ways of looking at this, isn't there? Sometimes we support people on what we would call a pathway zero, which is actually they went in, they were managing, but that ward would have a look and say, actually, they can go home, no problem at all. And pathway zero can also be augmented with our village, our community agencies, our Red Cross, and that does happen. But there are cases when it goes wrong, and I think, you probably hear the cases that go wrong rather than the cases that go well, because there are thousands of people a year that are discharged from hospital and supported well. We have what we would call a discharge to assess model, and that discharge to assess model is they go to now a hub where a decision is made around that person, a multi-agency decision is made about how do we manage that person, how do we get them home, what are the right methods, and often that will be through a therapist or someone going home with the individual, checking what the place is like, sorting it out, and then putting in a discharge to assess package of re-ablement support to get that person to where they need to be. Now that may only be for a week, because actually they'll do an assessment at the end of that week and say, actually, you can manage really well. Or, and sometimes that works, and sometimes that person doesn't work. It depends what family support they've got, because we do expect there to be family support as well. And what did your family do for you? Because if that person went into hospital with nothing, we want to get them back still needing nothing when they need it, and look at what those community supports are around that can also help them. Occasionally we get it wrong.
Yeah.
And the system breaks down.
And I respect that. Like, I've gone to the hospital now and explained it to them that he hasn't got anybody for his personal needs. They've got it now, so that's it. But you know what? It's like, I guess it's about neighbourhoods, it's about caring for each other, making sure that you get that information. Had I not gone into hospital, they said they didn't realise that at all. So thank you very much. Councillor Oakes, please now.
Thank you, Chair. I just wanted, Alice referred to the complex care team in Yeovil and how they operate. Can I just say, having recently had dealings with a doctor who was part of that team, it was one of the best examples of the NHS working for older people that I've seen in a long time. So basically, this was a gentleman who had interesting needs, came in, fully brief, full review, holistic approach, and then she brought in services that we struggled to get referrals to. And in a very short period of time, where he had his needs met and he improved. And you just wish that that service was, I mean, I said to her, can you do the rest of the home? Absolutely brilliant. And that is, I really hope that this is something that is protected and kept, because the NHS has a history of developing a good service and then scrapping it. Complex care team, you know, is absolutely fabulous. And we need to make sure everybody has an access to that team that is so focused on people with complex needs.
Thank you. Alice, we've slightly digressed, I apologise. And the thing is, my point about, I was saying, I think Rosemary was saying, the gentleman that I'm talking about has had an adapted house. And what I think about it is, and what Graham's thinking as well, I think, is that what we need to be doing is, he's had his house adapted for his age. So his house is really all on one level, and it's safety things in the bathroom. So actually, he's in a really good position. But what I'm saying to you is, what do we do about getting that message out about preparing for the future? We were talking in Sedgemoor very much, and I mentioned Sedgemoor, the area, because we were talking about homes for life. My daughter bought a home for life, original one, and I'm wondering whether we, as adults, need to take more responsibility about preparing for us getting a bit older. And I think I said this before, I got my husband to put bars outside the back door, because I said to him, if I fall off the back step, and he said, oh, don't do that, don't do that. He said, everybody will know we're old. Well, we are, you know, and this is the problem. But I said to him, we've got to be thinking, if we fell off the back step and we broke a leg or something, our life is very different. How do we get that message out there? How do we start taking responsibilities for ourselves? Because we all are living older. I mean, I hope to live to 120. Just letting you know. And the thing is, I think that we have to, we need to prepare, but I don't know how we get that message out. I mean, do you?
I think that's probably a good question for comms colleagues, isn't it? That is, I appreciate your point there. It's an interesting one, because I think many people don't perceive themselves to be vulnerable. You know, that generally people wouldn't identify as, oh, I'm a vulnerable adult of any age group, and perhaps don't anticipate that one day they might need support in their home or housing adaptations. And that's perhaps something that we need to reflect on for the recommendations as to how we can raise awareness, get people thinking about those things ahead of time, because it's also far more efficient, isn't it, if people are preparing rather than responding to a need once it develops, particularly if that issue has already caused them to deteriorate or have a fall or something like that. It's much better to be anticipating in advance what adaptations are needed.
think you're right. I think the prevention model that the NHS did many years ago, the prevention, I think is a great model of actually making us all think, but you're right. Okay, I'm going to go now to Councillor Bree.
Sorry, I can't hear the speaker.
Is that better?
Oh yeah.
So the report obviously highlights the impact of housing and place on people's health. How do we, and I think my colleague also mentioned this earlier, how do we contribute to that? And how do we, this may be more a question for you, Chair, in terms of how we connect with what developments happen with housing, the local plan. How can the adult and health scrutiny contribute to plans that are coming into place for housing? And I'm talking as I'm thinking. I haven't really worked this through, so I apologise. But I would appreciate people's thoughts on how we can contribute effectively to this and add some value to this discussion at the right point, because obviously housing is very important to people's health, but we don't really, as far as I know, we wouldn't normally have a say on it. So how can we get involved in that?
No.
So I think it's really important that you do. So we do have starting earlier on this week even, there was a meeting where and a plan where housing, health, social care got together to think through what is and public health. What do we think the housing strategy needs to look like for Somerset? I think what would be really useful is actually to help you to add to that. So it may be something that we do as a workshop to say, actually, this is what's coming, this is our thoughts, what else can we add to them? Looking at this report, and then we can put the recommendations there, and then you can scrutinise if those recommendations actually work. I think we need to think through how we do that. So it's being developed at the moment, let's work that through. You've had something in the past around homelessness, but I think this is far broader than that. This is what is our housing strategy for the new Somerset Council going forward, which should include your extra care housing, your housing fit for the future, your housing for younger people. It should include that whole model of what is the housing solution for us for Somerset. And within that, you'll also start to think through what does that look like. So we own some homes, we have some out, all of that modelling will be part of that process.
I think there's, oh, sorry, Henry.
On that light, then I think there is the combination of the chairs of all the scrutiny committees. I think this does kind of cover, communities, the children's, adult health. So it might be a topic that the scrutiny with the chairs and vice chairs of all of those committees come together to consider, rather than one particular scrutiny committee.
I think, if I may, we in the north here, I think greater collaboration with our planning and our planning policy would work much better with housing. I think the effect of new proposals for housing, we're building more housing, we have to build more housing, but we're not actually talking to the health authority when we build a house. And that's why this idea about building homes for life was such a great step in the right direction, because they were the doors were wheelchairs, they had every accessibility. And what I think we should be having discussions with our planning departments, our planning policy, and our policy makers to actually realise that as we are an ageing population, I hate to say that, but we need to be working in collaborative, really tight collaboration with our planning. Okay, can I go to Councillor Bailey, please?
Thank you, Chair. It's sort of referring back to my previous comment, and which Hilary mentioned as well. It's about integrating the processes, really. And I'll just give an example of, and I've had 3 of these, but this is the most recent one. Housing increases in Ilchester, and we've got one of the buses that's actually under threat, which is the 54, which goes from Yeovil to Ilchester, Somerton to Taunton. The surgery closes in Ilchester. So how do people get to Somerton to the surgery, of course? And so at least another 2 that I could example like this. And we come in at this stage where, in fact, the question is going to be, how do we fund that bus? The more question is, how do people access the services? So, and I'm working very closely and very supported by NHS Symphony on this. But the question is really, how do we think about this before we close the surgery and think about the interrelation? And I have the same with Martock and South Petherton, and with South Petherton when it moved from the centre of the village to the outside. The buses really need to be thought, how do people access it? Seemed to be a great idea in South Petherton, brand new surgery, right next to the hospital, pharmacy next door, but it's about half a kilometre from the village centre where it was before. How do people get to it? Well, we eventually extended the bus out there, the 81, but this was all done retrospectively. Oh my goodness, what do we do now? So it's sort of getting ahead of the game. And I think I understand totally why NHS Symphony is making these business decisions about closing one unit and focusing because of excellence and all those sort of things. Very appropriate. But it leaves people who need that sort of access without any at all. And there's lots of other things about the 54 could excuse me, go on with. But it just, you know, can we start hitting these things after the event and before the event really? Planning, good luck on that one. I'm seeing it planning at the moment, but I think it's where we exactly want to go. It's not my question, but I sit in feeling absolutely pointless in planning committee. But anyway, come back to the bus situation, how we might integrate these things at an earlier stage, perhaps.
Right, okay, well, there's a number of items there, but I think we need to, can I go to Councillor Ashton? They won't be forgotten, they've been picked up.
Thank you, Chair. Thank you, Chair. I think one of the issues here is that the speaker referred to updating local plan and the actual timing involved. The Somerset local plan is going to take many years to be formed, and even after that, it will be how it's implemented. I think there has to be investigated mechanism to influence current building at the moment, because phosphate block on large numbers of developments will come off as solutions are found now. And so there'll be a large numbers of houses and social housing coming on board because of the allocations. And that will arrive before a local plan is actually in place. So therefore, I think we have to look into a mechanism to be able to influence that before the local plan comes in, such as proportions of accessible houses and things like that, which actually came up yesterday. Well, there was a question of exec about a proportion of accessible houses that are built. So I think absolutely that area needs to be looked into, not just relying on the local plan carrying on something years in the future.
Thank you very much. Can I go to now? I think that's the last speaker, I think, because we need to, Councillor Woods. Unless there's
Yeah, I think we've had a lot of indication that our problems are with planning, and that is something we deal with. And it's also something that we need to think about, because our local plan for my own area was drawn up, I don't know, 10 years ago, but in the past. But now we see a situation like our buses starting to be withdrawn, that we're being asked to approve housing. But I was hoping when we were one council that our highways and our planning and everything would work together, which is what we wanted, because, you know, we're being asked to put houses in our villages where there's no buses, there's no accessibility. We're also being asked the type of houses. Well, we see 4-bedroom houses being built and they should be 2. And that's after we've had them at planning. So at planning, we must insist that we're getting the type of houses that our communities need. And that is basically smaller, unfortunately. I mean, that means that the door sizes ought to be bigger as well. You know, that's the sort of detail we're told to plan. No, that's not planning, that's sorry. Building regs. And I'm amazed that, you know, our house was built 20 years ago and all our doors were wide. And I thought that was the norm until I went on to planning and found, no, it doesn't happen automatically. That was your builder did the right thing, you know. So it's in our hands, not in anybody else's, really.
Okay, I've got 2 speakers now, and then we're going to do the wrap it up so that put things together. So we've got Councillor Bailey back, and then we've got Councillor Keach. You did put your hand up, Councillor Keach. Are you still with us? All right, well,
Chair, I'm now back with you.
lovely. Okay, we're just going to do Councillor Bailey and then I'll come to you. Thank you.
Thank you, Chair. It's a response to Councillor Ashton's comment because it can appear rather fruitless, the work we try to do in terms of planning, because there isn't in South Somerset a local plan, because there's no land supply. There isn't a county Somerset Council plan. That's not going to be there for years. What we have in Martock is a neighbourhood plan, which is currently running to 26, and we just started redoing the next one about 2 weeks ago. Now that's, I think, grabbing hold of it at a local level and saying, this is what we want, because there's no other framework around it and won't be for some time. And I think what we should be doing as a Somerset Council is encouraging, it's not easy, all local areas to have their own local neighbourhood plan, which says, this is what we think it should look like, this is what housing should be, with the support of all the expertise that's in Somerset Council about the sort of report that Alice has done in terms of the type of housing and that it's there, and about jobs as well, the whole gamut. Otherwise, we're just going to sit on our hands until most of us have gone through the next election, which I don't think is very fruitful for me, and I hope not for anybody else.
Okay, thank you. And we have our last speaker on this subject, and that is Councillor Keach, who's online.
Thank you very much, Chair. It's just on the question of transport and buses. My parents lived at Curry Rival, and the surgery there was closed many, many years ago, and everything went to Langport. Now, the actual normal buses, none of them fitted with surgery times. So the surgery got together with, I think, the parish council and the NHS, and they hired a local minibus service. And on a Friday, it was just called the surgery bus. If you had an appointment at the surgery, you could catch the bus and you didn't have to pay. If there was room, other people could use that bus. And you then had about 2 hours in Langport to do other things. And that was a wonderful service. I mean, my parents used that extensively until they moved into Ilminster. And I just wonder if that's something we ought to be looking at for some of our rural communities where there is no bus service. And obviously the 50, thinking about Curry Rival, the 54 goes through Curry Rival, and that's on the list to be closed. And if I think about Ilminster, okay, the actual town were okay, but most of my villages around Ilminster have no bus service, and yet their surgeries are in Ilminster. So are in Ilminster mainly, apart from the small one at Broadway. It's just a thought that maybe we need to think a little bit outside the box about this transport link, because it was very, very successful. Thank you.
Thank you very much. I think with the housing, today, Alice, I think it's a very wide scope area. I think in your recommendations, you have good examples of good practice working systems support people affected by poor housing. And this housing does affect, obviously, connectivity. It does affect living together, does affect poor housing, inefficient housing. It affects everything. It affects the poor way of life. And the interventions could be scaled to develop a health-driven approach that protects and prepares the population, you've rightly said. You've also said the new local plan does give us an opportunity to put new ideas into practice, if you've got one. And I think this is fine. I think what's the summing up today is what we would like you, and I don't know whether you can do this, whether it's too late, but I think what's been brought up today are the fact about supported housing, the tangible effect of the scrutiny to give an integrated approach to value. We want to make sure that what we're saying today does give value to the end result. We also want to raise the fact of working with planning, local policymakers, to make sure that we are getting the right type of housing to help to be a healthy option, far better. The buses with the connectivity also adds to better living standards, better living approach. And I think being able to influence housing accessibility is something if you're depending what planning you're on. I think in this part, we have been very successful in actually obtaining small bedroomed houses that people need, but not everywhere will have a different approach. So I think we need an integrated, but what I'd like you to do is be able to take this forward, the areas that you've heard today. There's no point in us raising these scrutiny issues that we feel very strong about if they're not going anywhere. So is that able, are you able to do that?
Thanks. Yes. So I've got a little bit more time to work with Trudy on the report, and I've made notes of all the comments that have been made today. It's really valuable getting your input and thoughts, and I think some of the comments are already reflected in the report, but there's a couple of points, particularly around neighbourhood planning, and that integration of decision making between different parts of the system, between primary care, transport, planning, that we could probably draw out a little bit more in the report. And so I'll try and see that reflected in the recommendations that are taken to exec in a couple of weeks.
Thank you. One of the things also I'd like to add is I've always fought very hard for minimum space standard housing, to give our homes and our families a better living standard. And it's not something that's always in the local plan, but I do think it's something health-wise that it could be progressed through health. That if we have minimum space standards for people, then they're put into a decent sized home with a decent sized garden, not massive, just a decent sized garden. The living, that their health and well-being, I think, will be greatly improved.
Yeah, absolutely agree. The minimum space standards do have good health evidence for them as well.
Certainly do. They're not always heard, but I keep banging the drum about them, and I've done for many years. So thank you very, very much for this, and I hope that you will take these points forward, please, so that we know that we've actually made a difference today, because that's the important thing, that we are scrutinising and we want our points taken forward. Is that okay? Thank you very much.
Thanks very much, everybody.
Thank you very much.
Thank you.
Okay, the last item on the report is the budget monitoring report number 9, item 8, and I invite Penny Gower to introduce this report, please. Maybe Gower, apologies.
It's okay, you can pronounce that however you want. Gower's fine, but however.
I'm so used to looking online now, I think.
That's okay. I assume I need to present the presentation.
Please, yes, please.
I think.
Are you able to make that a bit bigger?
No.
Yeah, just do it at the bottom and then make it bigger. That's it better. Thank you.
Okay.
Yeah, lovely.
So just to give you a quick overview of where the council's currently projecting. So at the moment, the council's projecting current overspend of 17.5 million for 23-24, which equates to roughly 3.6% of the net budget for the year. This is a slight improvement on the previous overspend of 18.3 million. Now, the forecast overspend for the year remains driven by both adult services, which are reporting an overspend of 14.9 million, and children's services that were reporting a 15.3 million. So together, these total 30.2 million and mask the fact that the rest of the council is currently forecasting an underspend of 12.7 million. Okay. If we move on to adult services for month 9, so as I stated, we're currently reporting a 14.9 million. However, the true overspend for adults is 24.2, but this is reduced due to many in-year mitigations and one-off funding, which we'll go into further detail on the next slide. Now, as you can see, we have not moved from month 7 to month 9. We've remained consistent with 14.9 million, and this is due to the work that operationally and commissioning are carrying out within adults. The main pressures continue to be residential and nursing for older people, so where the cost of beds are higher than we previously budgeted for. And we've also seen a dramatic increase in delivery and home care compared to where we thought we would be for the year. Mental health continues to be high cost placement, and with learning disabilities, it's the areas of supported living around market sustainability, so being able to maintain that market, and daycare, where we've continued to see the increase of usage of daycare to allow carers break and respite since COVID. And commissioning is reporting an overspend, as this is where the My Life, My Future project is currently reported. As previously stated, 5 million was put into the budget to be achieved this year, but we're only actually at this stage in time, we're only achieving 200k of that, so that's the pressure. So as mentioned, the in-year mitigations are 9.8 to 9.3 million, of which 2 of these are one-off funding. So these will not continue into next financial year. That is one-off money that we've received from the NHS, and the NHS are also, or the ICB, are currently funding our home care blocks. These home care blocks are continuing into next financial year. We've also received some market sustainability funding. So this was in relation to the workforce that we weren't previously anticipating but got announced mid-year. We're continuing, we've actually achieved a void saving of 0.3 million. So this is where we've been reviewing the supported living accommodation, also the specialised residential care placement. The work continues around reviewing the mental health high cost placements. So that's reviewing all of those, and that we have seen some, we are on target to achieve that. We've been focusing on the continuing healthcare to ensure that we're putting as many clients forward, individuals forward as possible to achieve that funding. And we're on target to achieve that. We're reviewing the high cost placement, reviewing interim placement, the one-to-one and overdue reviews, but we're all on target to be able to achieve these by the end of this financial year. That's it from me. I don't know, Mel, if you anything.
I think what you can see is and we have looked at this budget in audit here and everywhere I can think of at the moment, and because obviously there is an overspend in this. What I think we've done is been able to stabilise that overspend, and I think that's because of a lot of reasons, and I'll rehearse the reasons again here for you. The market out there it was a very difficult market in terms of recruitment in that market space. If you don't have our residents where they had lots of gaps and lots of people, but they couldn't manage, they were needing a massive amount of agency. And that agency cost was huge, and that was obviously passed on to us. International recruitment has, across the system, stabilised our market without a shadow of a doubt, whether that be in home care or whether that be in our residential and nursing care. It definitely has, and it has helped that market cost reduce in some areas, without a doubt. It's still a lot higher than we were before, but it has reduced. I think the other things that we're seeing in that market is the fact that we always wanted people to remain in their own homes, which is absolutely what people wanted and what we wanted. So our spend on domiciliary care, because of our international recruitment, has again helped people to stay in their own homes. The other thing we're noting is that people are also wondering whether they are ours, that we fund, or whether they're a self-funder, are staying in their own homes with living care. The living care market has exploded across the country and in Somerset. Again, a lot of that is via international recruitment, which again has helped us. What that has meant is that there are not so many people going into mainstream residential and nursing. You can see that both self-funders and ourselves, there are different models out there that are delivering differently. Therefore, you have now got a bit of supply in that market. When you have supply in your market, the price obviously comes down. It's a supply and demand model that we have. So that has helped us during this year to reduce that. However, we have still people in that market that are quite highly paid when they went in. We also have people, so in Somerset, we probably place about 650, well, we do place around 650 new people into our care market, into our residential and nursing care market a year. Out of that, about 600 people pass away. So we only place about 550 new people. The challenge we have, and the reason that the budget goes up, and the reason that next year's budget is going up, is because those that have been in the service a while, that have died, are probably at 555, 65, 70 pounds. Those that are coming into the service, that extra 600, is an awful lot more expensive. So you can see how the budget goes up. So what we've done this year is we've mitigated it with lots of one-off money. We've mitigated by trying to hold the price, by setting up lots of boards that help to mitigate, to make sure that our staff are doing what they can do. The other thing that we've changed over the year, and we will keep in for next year, and isn't particularly popular with anybody, is the fact that actually we place people now within a 30-mile radius. So if I can get my fee rate for somebody to place them within a 30-mile radius. We give people that choice, but actually we can only afford to place people in homes that we can afford to pay them. That doesn't go down very well. And I know you will all get in your boxes post which says, Mum wanted to stay here. And we'll be saying, I'm really sorry, but we can meet your needs, your care act needs here. I'm really sorry, but that's what we can do. Unless you as a family can top that up to go where they want to go. So some of that happens. It's uncomfortable, but we have to use our funding in as wisely as possible. So again, that has helped us to keep some of those prices as low as we can this year. It's still overspent, I know, but we've managed to stabilise.
I'm just making sure I don't miss anyone else, but Councillor Sally.
Thank you, Mel, Henry. Observing the exec, very historic exec yesterday. The comment that the 151 officer made about how you've done the equivalent of 10 accounts, 10 years of accounts in the council has done 10 years of accounts in 12 months is extraordinary. And I think that there must be so much pressure on the team, really, as for the greater good of our residents. And obviously, the residents in Somerset are concerned about what's going on with the budget, rightly so. But I do think it needs to be acknowledged just how hard you are working. What I hope won't get missed, and my sort of question, a little bit rhetorical, apologies, is that innovation doesn't get lost, because you are noted for that, and keep that part of it, and working with the VCSEs creatively, and let's hear the good stuff coming through. That's my question. Can you please continue giving us the good news and examples of what you're doing? Thank you.
And I think that's really important, because what we also know is if we keep people in their own home, we get communities working really well. We innovate, we use our micro-providers, we get our BCF working really well. It's the right thing for people. You get the right thing for people, money gets saved. It just happens. It's what it does. So we will continue to do that. We continue to drive that. We're looking at, and Emily may want to jump in, we're looking at how we can use AI to help us going forward. What does that do? How do we use things differently? I think all of that will help us to be a modern, fit for the future service. We know there's not going to be loads more money. Let's be honest, there'll always be less money. So we have to innovate. And sometimes by pushing us to think differently, we innovate quicker. So we won't stop doing that.
Can I, Councillor Ashton, please?
Yeah.
Yes, this question will probably expose my misunderstanding of the system here. So I think you said there was an underachievement in commissioning, but I don't quite understand how that equates to an overspend in the outturn here. The mechanism doesn't seem to sit. So I think a little bit more explanation there would help. Thank you.
No, within commissioning is an overspend. We've underachieved the My Life, My Future saving. The saving was put in for 5 million. We've only achieved 0.3 million of that saving. Okay.
And that's what we expected to achieve. So we knew at the beginning of the year we weren't going to get 5 million out of this. It takes us a while in year to produce that. We know over a 2-year period we will get the 10 million that we expected, and we are on track to delivering that. It's been a little bit of delay, because what happens is some of this is around people leaving the service and doing things differently. So, for example, what we're trying to do as part of this, some of the data that we've got around this is about some of the plans that we have, is saying we'll place less people in res and nursing care, and we'll keep them in their own homes, and we'll reduce the amount of care going into those homes because we've re-abled them better. Well, there's always a little bit of a lag, isn't there? Because we may place less people, but we also need people to leave that service, to die, to move on from those services, to be able to make the saving. So we know there's a lag. We are tracking all of that. We track our mortality rates. We track all of that as part of this process. And that was built into the baselining at the beginning of it. So we knew 18-month, 2-year lag. And for some of it, there's a 3-year lag, particularly in our learning disability, where we have to change the way in which we're working. That takes a bit longer. So our savings, what plan was always 2, 3, 4 years hence. But we will get to the 10 million in the 2 years.
Okay. Thank you, Mel. You haven't got me yet. You're waiting to hear me. Councillor Bruce.
Thank you, Chair. A couple of things. One observation, really, what you mentioned about the recruitment, international recruitment, kind of highlights again that we do need to look at workforce. I'd really like an update on where we are, how it's going. Sounds like it's going well, which is encouraging, but I'd like to know the plans of that. So that's the first point. Second point was you mentioned about placing people within a radius of 30 miles, I think you said. Just like to know a bit more about the mitigation of that in terms of how relatives get to then see that person regularly. Is there any kind of transport services and what's happening with that? Or is it, I know they're difficult decisions, but just like to know if it was possible to put something like that in, if it isn't already. Thank you.
Okay, so I'll start with our workforce. So we have a workforce board that meets on a monthly basis and a workforce plan. I'm going to say international recruitment has been fantastic. However, there is a risk. And there's a real risk in this area nationally and in Somerset. And the risk level here is about how the Home Office, and this isn't a political point whatsoever, it's a fact, how the Home Office enable people to come to Somerset, to the not to Somerset, internationally. There is a gap between people coming to it and understanding, is there work for them? And they didn't do that very well. So what we have across the country, so they offered licenses, and they offered licenses to lots of people. And those licenses they offered, they didn't always check whether they were CQC registered, and therefore they were the right licenses to be given people. So there is a huge risk around modern slavery, around corruption here for us as a nation. Now, we've done a lot of work on that, and we're pushing, because what ends up happening and can end up happening is, from a county council point of view, from a statutory duty point of view, we have to have oversight of a market and also the people that are working in that market. If we don't even know they're here, it's really difficult to have that oversight. So we have gone back to the Home Office to say, if you're going to do this, these are the things that you need to put in place to help us, because I don't know who's here. And therefore, I can't make sure that it is safe, that actually the ethical framework which we should have in place to support people is in place. So we know that there's a risk area for us in this space. We also know that the government have changed the rules halfway through. So they are now saying you cannot bring your spouse with you. We also know a lot of people that came here have brought their spouses, and lo and behold, they're working in other parts of our system. So they may be working in the health system, they may be working in elsewhere. So that, again, may be a problem for us going on. We're keeping a real look at it and a real eye on it, both nationally and locally, to try and work that through. So although it's fantastic at the moment, it's managing our market, it's brought people in, it's not a long-term fix. So the other part of that is, how do we make sure we have a workforce fit for the future? Skills for Care are working, dependent, we will at some stage have an election this year, and dependent on what happens at that election, different parties are looking at different ways of working. We really missed a trick, in my mind, that we did a workforce plan for health. We have not done a workforce plan for social care. So we are pushing from an ADAS perspective and with Skills for Care to make sure that the parties in their manifesto have a workforce plan for social care as well. And when social care, I mean everything. Some may not. That's a choice that they make, isn't it? I can try and influence, or we can try and influence, but you can't make. So so Skills for Care, I know, are working with some parties to have a look at that workforce plan, what that look like. That will help us. If you look at the manifestos at the moment, you will see some manifestos may be slightly different from others. I'm not having a political conversation here. It is about, that's the facts. And some will look at those workforce situations. So within Somerset, we will also know from a social care point of view, we have struggled to recruit for social workers. And we are using Morgan Hunt, which is a recruitment agency that is recruiting in Southern Africa for us around social workers. We have got 15 currently. 15, thank you, 15 at the moment. We have gone back to Morgan Hunt to ask for another 10 social workers. They have enriched the way in which we have a diverse workers within ourselves here. It's been fantastic, and we will continue to do that because we can recruit in that area. However, we are still working with our universities. But if you know, we've got a university in Somerset, In Yeovil, which recruits to social workers, they have a fallow year this year. They had nobody wanting to go there to recruit. We need to work on that. So it is about how do you manage that workforce. You have asked for numerous occasions for us to bring here a workforce plan for you to see. I think it is a workshop that we should be doing going forward. But again, that's something that we need to look at.
Very much. Well, can we go to Councillor Bailey, please?
Thank you, Chair. Yes, thank you for your report. It's sobering news as always, but I think I really saw a light in the fact that you've reduced your waiting terms from 150 to 2, and I think that's and I'm sure we're all going along to parish council meetings where it seems I try to think beforehand what I can say that's positive in a meeting, a little light, because it's all doom and gloom, or it appears to be from their sides. And I think that's one I'll carry with me out of this meeting. And I sometimes think we're almost, as councillors, we fill the role of the GP, where we have all the sort of threads coming towards us, and we're not specialists in any of them really. Hence my remark about the integration earlier on. The question I really had, apart from complimenting you on that, was the point you made about the cheaper beds going out the system, the more expensive coming in. Is there a point that you're looking forward where those bed prices may come down? I'm sort of thinking about, the classic school bubble that's gone through and all these sort of things where, so at some point, they're not all going to be 900, let's say, or whatever the figure is from 500. But there's going to be some drop in there at the time. And I can see, even though I'm not looking at him, Graham shaking his head. But, so I'm asking the question really, or is that the direction of travel? And that's where it'll be. Thank you.
So 70% of the workforce within care, and more in some places less than others, is on the national minimum wage. It is right that national minimum wage has gone up. I have no problem about that. Yeah. It has gone up this year. It was not funded to go up. Therefore, a cost of a care home, let's take that for an example. They've now got, yes, inflation has started to come down. However, a lot of our care homes, to build them, took out capital. And you will see the price of capital and mortgages, etc., has gone up. So that's but the majority of it is around staffing, and staffing rightly so. We should be paying the right amount. It isn't an easy job, so I can't see it coming down. What we do with our providers, and we have really good providers in Somerset who will open book with us and talk to us about actually this is the cost of care, and they're honest about it, and they show their books, and our teams help them. They have a look at them. They say, Crumbs, perhaps you could have a tweak here. Have you thought about this? Is there ways in which we can help you? I cannot see the price of care coming down. We are still, clearly is, a low fee payer compared to other areas. We are, but that's because we work really hard with our providers to support them in different ways. Hence, the complex care teams coming in to help you in a different way. There's lots of ways in which you can support, which isn't just fee based. And we have we don't have lots of the big nationals in Somerset, which is good because actually sometimes the big nationals have even huge overheads, whereas our Somerset population, they don't as much. So no, the answer is I can't see it coming down. I can see it levelling off. Yeah. So for example, if we look at our home care market, the reason we've got a vibrant home care market, yes, international group, but we're paying properly. So we are paying £25 an hour to that market. We have stabilised it. So you wouldn't then start to put lots more money into that market because we've stabilised it. So you'll start to see some will level off for us and some will continue to need a little bit more to get us to a price point that's probably okay. But then you won't see the huge jumps. At the moment, you see the big jumps because we started very, very low. We were a really low fee pay. We did really well and getting the market where it wanted to be. Yeah, not great, was it? But that's where we were.
Thank you. Now, can I bring Emily back? Or should I cut you off, Emily? My apologies.
No, that's fine. It was just in relation to Councillor Bruce's second question in relation to the 30 mile an hour distance and how do we support family members in order to maintain that very valued contact with individuals. And there's not a blanket response to it. It's very much an individual basis, but there's absolutely something that's taken into consideration when we're making any of those really quite complex and challenging decisions as well. They're not easy for anybody, for family members to hear and have those conversations, but likewise for our workforce as well to deliver some of those conversations as well. We're looking at our community and voluntary sector as well. So we look at any sort of voluntary drivers, anything along those lines. We work with our care providers as well to see what other options there are. We also make sure that that they're realistic choice options as well, so that if there's not a bus route or anything along those lines, what else can we consider for individuals? So just to give some reassurance that they're looked at in an individual experience of somebody, not as a blanket response.
Thank you. Could I go to Councillor?
Yeah, I just wanted to make the point sort of historically how social care and residential nursing care has changed since the 1980s when I first sort of got involved in it. And the can I turn me on?
I think it's on.
It's on.
It's not lit up.
Yeah, I'm in the house, don't worry. What's actually happened is that the people who used to go into our care homes in the 1980s, equivalents would now be working in those care homes, because there used to be people going homes because maybe they're a little bit incontinent or whatever. These days, the people who are placed by this authority, certainly in most cases, have a whole range of needs. So the needs have gone up. So what's happening is over time, there will be less people going into the homes, more people sort of supported in the community. But those people have a higher range of needs, and they need more staff to look after them. So that pushes the fee up. The other thing that Somerset, to its credit, is doing is moving to stop what has gone on for the lifetime of modern care homes, and that is the fact that cross-subsidy, it still exists, but self-funders pay to subsidise this council. They used to do it a lot, now they're doing it less, and there will come a point when we won't ask whether somebody's a self-funder or a local authority, because the fee will be entirely based on need. And I look forward to that day, and we're moving towards that. And that's when you will get the levelling out, and you will then get a slowing of the rise in this change. But I think that no matter what people may say, expect the cost of care to steadily rise, simply because you need to employ people. Some of them you have to bring in from other continents, excellent staff, and you need to pay these people a wage. And maybe this committee perhaps should come and visit my home, and then you can get the insight into some of the people we look after and the way they behave. You know, they're lovely people, but you need good experienced staff, and you need quite a few of them. And I will just finally say, social care staff at the moment are being very challenging, but supportive at the same time.
Thank you, Graham. Can I go to Councillor Woods, please?
Hello. I did have a series of questions to ask. You'll be happy to hear I've cut some of them down. But the cost of home care blocks is being held by the ICB. Is that right? But basically by the health service. Now, you're saying that's being held for 2 years. Yes. I'm worried about this because there's a distinct if you come into the point that you have NHS care and you're discharged from hospital, for example, you get that free, right? But if I'm discharged from hospital, but I'm not quite there, I have to pay, yeah? That's the situation. Now, how long is the NHS going to be supporting people that come out of hospital? And it's not clear, because I've had somebody come out of hospital and they were terminally ill. except 12 weeks later, the person was still with us, I'm glad to say, but then the care from the NHS stopped. But how long can we rely on the NHS to give us that care? Because I think a lot of people are now coming out of hospital within that you know, they're on the last legs. But when it comes down to it, they get home and they're almost fine. Not fine, but need care. But as a county, we're asking them to pay for it. Now that seems a anomaly.
Well, it's not an anomaly really, is it? Because actually, if you can afford to pay for your care, why is the state paying for that? There's something in there for me. However, and that's the reality of it. So in this is just a one-off grant fund that they've given us to help us out. It's now in our base budget. They shouldn't be funding this bit, really. It should be us, but we've worked with them long enough. When we're struggling to fund, if they had some additional money that they had available, then they'd given it to us for a couple of years so that we could develop it. We've developed it. It's in our base budget for next year. What you're talking about is discharge. It is funding when somebody comes out of hospital. Now, there is a limited time. It's about re-abling somebody. So if they need re-ablement, we will fund the re-able package together, and it comes out of what we call the Better Care Fund anyway. So it isn't a joint funding. It isn't one or the other. It's how we fund things together. And we're only going to fund that whilst that re-ablement is happening, or whilst that individual needs that sort of support. And it is up to, and let me phrase, up to 6 weeks. It's a maximum of, not more than, not less than, it's not 12 weeks, it's 6 weeks care. Now, it's maximum. It's not saying that's free for 6 months. You're not entitled to that. You're entitled to support when you need it. It's like saying, you know, if I needed this, I can have it for a period of time. It's not, you know, it's needs-led. So some people may only need that for 1 day. I'm not sure they ever needed it in the first place, but hey ho. But they may need it for 48 hours, or they may need it for a week just to settle in. And then we stop that. We then have a look at, are you have you got enough sufficient funds yourself to then pay for it? This is how you could do it. Or we'll do a Care Act assessment and say, actually, this is what amount of money that we will fund for you. So there's those options. It's really clear about how we do that. But if people can afford their care, that's what should happen. The state won't be paying for that. That's how our system works.
I know, Mel, you've got me. I think as you know, I've been a little upset this week about a number of items, and I think nobody wants to see cuts, but we have a scrutiny committee. We are scrutinising the budget. That's what we're here for. We're not an appreciation society, but I have to take this opportunity to thank you, Mel, because you've had a tremendous amount of work to do, and we do appreciate it. Even though we're scrutinising, we do appreciate, and the ladies, Emily, and you know, honestly, we do appreciate. But we are a scrutiny, and you do expect us to scrutinise. So I just first of all wanted to say that in line with Councillor Sully, really, that we know the tremendous work you've been doing. And if you ever get hijacked, God help us all. So this won't happen, because I'll make sure. But I've been very unhappy about the mental health, the budget that was reduced, because I feel it's such an emotive area, and I feel at the moment it's just an area where we shouldn't have been cut that. I fought for it the last 3 days. You've seen me. You're bored with what I've said. Independent living. I'm fighting for all the things that we keep talking about here. But so I will put you through that. But what I would like to say is, I think that we have a workforce board. There should be a workforce board on the direction of travel. I wonder whether eventually if we are going to get, we're going to get people back in their homes, which I absolutely advocate as something I think we should happen, and I think people are better for it. I've got evidence of it, so have you. When we eventually get most people, or many as we can, do you think that we'll get a capital receipt off the nursing homes? Because with the greatest respect, and the nursing home, residential homes, more residential homes. I mean, we won't need nursing homes. I think we'll always need that extra care. But there are a number of residential homes, especially in the north here, well, one in particular that has been closed. And what I'm suggesting is that capital receipt surely could come into, will it be able to come into the budget if they have plans to to get rid of those nursing homes, because it's a physical building. With all greatest respect, they wouldn't be needed if we're going to actually get those people coming to our homes and looking after us.
So it depends if
Whatever.
it depends who owns it, doesn't it? So if it's a private company that owns it, it's up to them. They've bought the land, it's theirs. They will do with it what they want. If it is homes that we so if we think about the Somerset care homes, some of those Somerset care homes we've leased to Somerset Care, and obviously that is part of the portfolio for care. It's part of the portfolio where we look at whether do we sell them, what do we do with them? Do we, do you move them on? Do you change them into extra care housing? So what we need to look at is what is the housing solution, as we've already talked about today, but what is the housing solution to keep people at home? I think personally, residential care will eventually probably not exist in the way it does today, and you'll have extra care housing, but you will always need some sort of support. And nursing care will always be about, no doubt about that. And you're not going anywhere because we absolutely need that. But there is a question for me as how much residential care you will need in the future, question mark. It'll be what people choose, but if you get the right housing solutions right, if you can get the right models in place for people, you may not need as much of that. However, we've got some homes that are ours, some homes that are not. And also you'll have some homes that just run out of their life span because the buildings can't be adapted anymore, they can't be remodeled, and obviously those you'll sell. You may knock the land down and put something else that's modern up. So those are sort of the conversations we have, and that's part of the strategy that's being written.
That's what I was trying to say, the direction of travel, the solution. I think people who can afford to have care in their homes, and they want to, and the people I've spoken to absolutely want to. It's what they've saved their lives. They've had a different kind of life, and they're very happy to have that care. And the thing I've noticed was that people can have care in their homes at the same cost as in a nursing home. And this has been quite, I didn't realise this. What I'm asking is how well can we get that message out to people? Because I know people that were extremely well off, who could have paid for their own, didn't realise it was available. How do we get that message out there?
I think the message is starting to happen. So living care wasn't something that was around probably, I don't know, even 5 years ago in the way it currently is. It's a model that's out there for some people now. It may have been that, but it wasn't as prevalent as it is now. Whereas living care now is quite common. And that means somebody stays in your home if you've got a if you've got a bedroom for them, and that sort of thing, they can go and stay in there for you. It's growing. And I know it's a growing model in Somerset because we know that that's what they're doing. But rather than domiciliary care, it's another form of domiciliary care. That's out there for people that can afford it. The challenge for us as a local authority is it's not always cheaper than using on our fee rates, maybe for a private supply, it may be cheaper, private funder, it may be cheaper to have a living care, maybe 900, 1,100 a week. But there's a real challenge for us about how we spend public money and how we use that public money for everybody. It has to be done on an individual basis. But there is a real challenge for us about, if it costs us more to keep somebody in their own home, and I can afford, and I've got something else that will meet their needs, we do have to have that conversation with people. So living care is out there for some people. Sometimes as a local authority, we can't afford it. And we have to have a really good conversation with families about, if you want to do that, you may have to top up a bit. And there is those conversations we have.
Well, thank you for that. I've never known anyone that hasn't had to top up, to be honest. I've got to be truthful, but there we are. But and the mental health, I know I don't want me to touch on this, but the areas that I've been bringing up, they do, in some areas are worse than others. We do know that. It feels the wrong time to me. No time's the right time, but this feels wrong to me.
No savings that I put forward are savings that in an ideal world we'd want to put forward. I can't sit there and say that, but we have to balance the budget. And if commissioners came in, which if we have a 1-for-1, they would slash probably a few more of the bits that I would never want to slash. If you look at Birmingham and what they've taken out, I looked at their children's services that commissioners have just decimated. I should be getting from the DAS what they're doing in adults. We have to do some of them. It would happen anyway. If we offer the 1-for-1, it'll happen anyway. 1-for-4, so it'll happen anyway. That's what's going to happen. Therefore, what we need to do as a council is put forward the things that are the least worst and things that we can think through about how else can we do this? How else can we deliver it or deliver a service slightly differently, but a bit cheaper? And that particular one is something that we've looked at. How can we do this slightly differently? How can we change the contract? How can we do things differently? Never ideal, but it does give us that opportunity to innovate, to think differently when we have to.
Thank you. Councillor Woods.
Yeah, some time ago, we were given money from the government, as far as I'm aware, to look after, to help educate our own carers. Now, that was 19 million, and that was between Bridgewater and Minehead. Now, where's that gone? I haven't heard any more about it since.
I'm not quite sure what I don't know what you're. I have no idea. I can't even.
No,
I can't even think that through.
This is a question that you can ask Mel of the committee, if that's okay.
Yeah, I mean, we had money coming into the council so we could educate our own carers. So we brought in people from locally and we educated them so they could become carers. Now we've heard no more about that.
Is that the Bridgewater
The Bridgewater Hospital.
That's, yeah, this is the Bridgewater Hospital. There was the training, that's still going on. Yeah.
2 more years.
Yeah.
Oh, right, okay, thank you very much. That's the Bridgewater Academy you're talking about.
Well, yes, presumably
Yes.
it changed it to Bridgewater, but
it was always
for the
Bridgewater.
whole of the county.
Yeah. So what you're talking about, that was capital money
Yeah,
to sort the building out there, to design the building and work that through. That is still ongoing. And that's still there, that they're looking at that, that's still in train.
Yeah.
So that was capital money to manage the bit, to do the build. Because I know the front of that build has to stay, bits and bobs have to stay. Yes, sorry, that is still going.
so what happened to the West Somerset bit?
That West Somerset bit is still there, and I think that's probably coming on quicker than the Bridgewater piece. That's all in train.
Oh,
That's not stopped, it's all in train.
that's lovely. We'd love to see it happen. Yeah, because we said at the time, we didn't want it all to go to Bridgewater because it was something for Somerset.
It's not, can I just explain, it's not just about Bridgewater, it's the training, it's the academy that's in Bridgewater. You're utilising Bridgewater Hospital, they're rechanging it, they're making it, it will not just be, it's not about Bridgewater, it's just where the building's located. That's all it is, about where the building is located. It might be that they turn around and say, this is a bigger building, more accessible, better for other areas to come in as well. But I don't think it's for this meeting, I don't think I can say that. All right.
I'd like it to be for this meeting. That's why I brought it up.
We'll get an update in a future meeting.
Something else that perhaps isn't for this meeting, because it's something I picked up at children's meeting, and it's how the children leaving care are cared for, the 16 to 24-year-olds. And it was mentioned there was something happening in Dolverton, and I worried about that.
Perhaps that's, if it's an individual case or something, we can probably take it outside here, but I won't probably know about that individual case. But when we talk about pathways to independence and moving from children to adults, you did have a workshop a while ago around that and some plans around that. If you want to continue to have some thoughts on what happens to our youngsters, how do we go from what is that transitioning process, we can always come back and have a conversation with you at a later stage. But I think at that point, you'd want to join the committee, as you did have last time, to have that conversation.
Yeah, we have had that, and it was very interesting, and maybe an update at some point, that would be really good. I think that'd be very, very valued. Okay, members, I think, oh, sorry, Hilary, sorry, Councillor Woods, sorry.
Thank you. I'm fairly certain that you're on top of this, but all this talk about moving towards living care and people being looked after in their homes and everything, please keep in mind the impact of loneliness on people, because if they're moving to being looked after in their own homes, a carer coming in for a short amount of time, a couple of times a day, 3 times a day, is not enough, and the impact of loneliness is tremendous. So please keep that in the top of your minds.
And there's something about quality of life, isn't it? If somebody is coming in 4 times a day with 2 people coming in to help that person sit in a chair, to get up again, there's that real challenge about how do we wrap around families, or if the cost of that is actually how do we talk to the person about what do they want next. So that's an individual thing that actually we work towards. And you're right, if it is just that and there's nobody else coming in to see that person, what do we do, and how do we do that differently? And would a different model of housing help that person? So, you know, extra care housing, if that person takes, look at all the Carthy Stones or whatever else are out there. You know, it's about finding the right solution, the right housing solution, but perhaps there's a bit of support for that. Yeah, I don't disagree with you.
Well, Mel, I mean, this is the thing with you. This is the problem we've got, is that you have got it covered. And scrutinise as much as we do, you know, you have, all you ladies, Emily, Penny, you have covered it very, very well. But I think as a committee, I think we've done a good job, because I think that's what we're here for. We are, Rosemary's shaking her head, but we can't do everything. But the thing is, I think we tried very, very hard. And I think the budget, I've been at 3 meetings this week, and you know that, Mel, you've seen me walk in the door and thought, oh no. And the thing is, it's a very emotive subject. You know, you're talking about independent living, you're talking about mental health, we're talking about employment, all the things I would never want anything in adults care to be cut. That's my stand, that's where I started at, and that's where I want to carry on. But I guess we are where we are. And I have confidence, I think, that you have listened today, and you know where our sensitivities are. You certainly know where mine are. And I think you understand. And I think that's half the battle, quite honestly. So I want to thank you again. I look forward to you coming to the next meeting, giving us more absolutely exciting news. And thank you very much. Thank you. Okay, members, we are now, I think the summing up, I think Jenny's probably managed to capture everything. I think we've all raised very, very important issues. But I think one of the things I think we will have to consider, it's very difficult at the moment about locations, about times, and about rooms and everything else. But obviously we will talk in the next meeting about getting a little workshop where we can gather the things together that we are really worried about, where we're not happy, where we can perhaps have one at a time, where we really thrash it out. I think that would be a really good thing. So is everybody happy with that? Please, everybody happy? If you could smile, let me know, that'd be great. Thank you very much. Okay, so I don't believe there is any item 9, no urgent business. Okay, so I thank you all for coming today. Thank you for your input. It's very, very valid, and it's been taken on board, and I appreciate it very much. And thank you. But I declare this the end of the meeting. Thank you.